Lung cancer accounts for more deaths worldwide than any other cancer. A group of pioneering lung cancer specialists realized there was a great need for scientists to focus on this disease. Their belief was that researchers could make advances in lung cancer more rapidly if they shared knowledge on an international basis and took a multidisciplinary approach to all aspects of the disease. It was with this mission in mind the group formed the International Association for the Study of Lung Cancer, known as the IASLC, in 1974. The same year, the first board of directors convened and 250 people joined the organization.
The founders of the IASLC had a vision that lung cancer was important, and that whether you were a surgeon or an oncologist or a pulmonologist or a radiologist or a pathologist, many people would need to focus their career and their research efforts and their educational efforts on lung cancer, as again opposed to operating on many parts of the body or whatever. And so they had an insight that people would work on lung cancer and that they would work together, and that by working together they would make advances more rapidly.
It was recognized that lung cancer spread to regional lymph nodes. Dr. Naruki, a Japanese surgeon, developed lymph node mapping. This early systematic categorization of lymph node regions was important for doctors to help determine a patient's prognosis.
This concept is superb. According to this lymph node map, people can designate where the lymph node is or what part of lymph node is swollen, and according to this map, the people are able to compare the prognosis according to the status of lymph node metastasis. I think this is a benchmark, a landmark article in the history of lung cancer in the 1970s.
Soon after, Dr. Clifton Mountain, a surgeon and thoracic oncologist from MD Anderson, worked with Dr. David Carr, a medical oncologist from the Mayo Clinic, to develop the first data-driven revisions to the TNM classification for lung cancer. Their proposals would be adopted by the American Joint Committee on Cancer and the Union for International Cancer Control, the two bodies responsible for regulation of the TNM classification worldwide. This would also be the basis of future IASLC developments in this area. In the area of pulmonology, a new bronchoscope was developed that wasn't rigid, making diagnosis easier. The device could also extend beyond the trachea and carina to provide more detail.
And so the advent of the fiber optic bronchoscopy was a true revolution, because you could examine the bronchial airways much more in depth, looking much more at peripheral airways and taking samples of peripheral airways, certainly when you used the guidance of fluoroscopy. So this massively improved our abilities to get a preoperative diagnosis of peripheral lung cancer.
Just a year later, in 1976, researchers were diving deeper into the causes of lung cancer. They found a clear association between smoking and lung cancer. It's hard to imagine now, but in the 70s, promotion and advertising were rampant. Even Ronald Reagan, physicians, and Santa could push cigarettes. At the time, in some countries, 40% of women and 80% of men smoked. But smoking wasn't the only cause of lung cancer. Researchers were also looking into how air pollution, asbestos, and radiation caused the disease.
Then it started looking at air particles, so pollution and contamination in more urban sites than, say, in rural ones. So is it fine particulate matter? Is it cadmium? Is it the metals that are in air pollution that are causing lung cancer and their contribution to it? And note throughout this that it very definitely is clear that the more polluted these more urban populated areas are, that it still is this tobacco epidemic which is significantly increasing the number of deaths too.
In 1978, the IASLC organized its first World Conference on Lung Cancer. Held in Hilton Head, South Carolina, more than 100 people attended the conference from 16 different countries. It would set the precedent for the largest gathering on lung cancer research worldwide.
Well, to my knowledge, there's also nothing like the IASLC World Conferences on Lung Cancer. They have been, originally they were every 3 years, then every 2 years. Now we're going to yearly. Compared to other meetings, they rotate around the world. That's very important because it's one of the guiding principles for IASLC is engagement. And there just aren't enough opportunities for people from Asia to fly to North America or from Europe to fly to Asia. So it allows people to meet internationally, but it also allows a regional focus for that particular meeting.
They are a great engine for coming up with research ideas. The ability to sit in a room or a conference hall with others and then discuss what you've just heard is what spawns new ideas to be researched, new areas to inquire. And very often, I'm aware of a number of trials that have their origins in a small conversation that occurred at the back of some sort of conference hall.
Having proven that the removal of the whole lung by pneumonectomy was not always necessary for lung cancer, surgeons in the 70s went further and evaluated the role of sublobar resections such as segmentectomy or wedge resection. While these lesser resections became valid options for patients who were unlikely to tolerate lobectomy safely, their use for fitter patients was controversial. In radiation oncology, it was the introduction of computed tomography, known as the CT scan.
Up until then, most radiotherapy plan was based on chest X-ray. But as you and I know, the human body is three-dimensional. So CT scan gave us to build the planning on three-dimensional images.
In the area of chemotherapy, researchers developed cisplatin-based combination therapy for both non-small cell lung cancer and small cell lung cancer. This method is employed today, some 35 years after its initial development. And finally, in the area of immunology, scientists knew immune therapies worked in the area of infectious disease vaccines, and they wondered if there was a potential in the fight against cancer.
But the first recognized hint that that might be true is the observation that it appeared that patients who got post-operative infections did better than those that didn't. And the thought was that that was a stimulation of the immune response in patients with lung cancer that had an anti-cancer effect. And so in the 70s, some of those hypotheses were being tested by injecting infectious agents into the lung after surgery. And there was an early report in the 70s that did result in prolonged survival.
Research in the area of supportive care wasn't being done in the 70s because of the severity of lung cancer. Most publications focused on issues of palliative and end-of-life care. It wouldn't be until the 80s we'd see breakthroughs in this area. But the breakthroughs are coming. We see that the 1970s are formative years for the IASLC and for lung cancer research. Soon, we'll see how the organization unites internationally, driving research in the 80s.